Stage 1, Assessment and Confirmation of Adhesion. An intraoral examination was performed to assess the oropharynx following a previous tonsillectomy. This revealed that the posterior pillar was adherent to both the posterior oropharynx and the posterior margin of the soft palate. Notably, a single orifice, approximately 0.5 to 1 cm in diameter, was observed on the posterior aspect of the uvula. To confirm whether this orifice communicated with the nasopharynx or was a blind-ended cavity, a black Nelaton tube was used, guided by nasoendoscopy through each nostril. This confirmed that both Nelaton tubes successfully passed through the inferior choanine, emerging at the posterior orifice of the uvula. Stage 2, Surgical Preparation and Flap Creation. After confirming communication between the orifice and the oropharynx, we employed the Madame Butterfly palatal flap technique. The flap area was first marked, and an injection solution made of lidocaine and epinephrine was administered to provide local anesthesia and control bleeding. Scar tissue and oral mucosa were then excised in the submucosal plane, with care taken to preserve the underlying muscular layer. We detached the scarred tissue at the orifice edge, and the muscular component of the flap was sutured with Vicryl to minimize the exposed mucosal area. Stage 3, Mucosal Repositioning. Once the muscle layers were gathered, the nasopharyngeal mucosa was repositioned and sutured to the mucosa at the flap's periphery. This critical step promotes proper healing and restores functionality to the newly created connection. Stage 4, Placement of endotracheal tubes. After completing the suturing of the fibrotic area, 2 size 5 uncuffed endotracheal tubes were inserted through each nostril into the oropharyngeal space. The proximal ends of these tubes were sutured together, and a celastic sheet was attached to the tube's anterior ends. This arrangement helps maintain space and prevents new adhesions from forming in the nasopharynx post-ETT removal. Stage 5, final adjustments and retention. The proximal sections of the ETTs were trimmed and sutured together, with sterile gauze placed beneath these sutures to prevent damage or infection in the columella region. The ETTs and the attached celastic sheet were retained for 2 weeks to facilitate healing. Stage 6, removal of tubes and celastic sheet. After 2 weeks, the endotracheal tubes and celastic sheet were carefully removed under general anesthesia, completing the surgical procedure aimed at effectively managing post-tonsillectomy adhesions.